Welcome to this explainer. Today, we're diving into a fascinating yet really tragic medical mystery surrounding a 90-year-old patient. We're going to uncover exactly why a deeply misunderstood type of cancer is claiming so many lives. We generally trust standard lab tests to give us the absolute truth about a diagnosis. But what happens when those tests fundamentally disagree with what the human eye can clearly see on a medical scan?
So let's explore this central paradox. It's literally a doctor's worst nightmare. You run a biopsy, the lab results come back actually looking somewhat favorable, but the imaging shows a completely different, highly aggressive beast.
Section 1, the biomarker paradox. Let's look at the initial evidence from our patient's case to see exactly how this plays out in a real clinic.
Okay, picture this. When this 90-year-old patient first arrived for an assessment, the clinical exams immediately confirmed something was definitely wrong. She presented with extensive clinical thickening, which is basically a really dense, firm area right in the central portion of her right breast, along with some enlarged lymph nodes. Naturally, this physical presentation prompted doctors to do a much deeper histological investigation to figure out what kind of tumor they were up against.
So they run a standard immunohistochemical panel, and the results are surprisingly optimistic. As you can see, the estrogen receptor was positive. That's generally a good thing because it rules out a highly aggressive triple-negative tumor. Then you've got HER2, EGFR, and the CK markers all coming back negative. That points to a standard-risk non-basal type tumor. If you're a doctor looking at these results, you'd probably think, okay, the prognosis here is manageable. On paper, it looks like a fight that standard treatments can win.
But here's the kicker. These standard tests, which, by the way, are usually incredibly reliable for predicting how most breast cancers will behave, completely failed to warn the doctors about the truly fatal nature of the disease hiding in her tissue. The lab results essentially told a lie by omission.
Section 2, visualizing the threat. And this brings us to the actual imaging, which is where the true danger finally revealed itself.
The actual mammograms expose the complex reality going on inside the breast. You can clearly see those large, circular masses. But look a bit closer at the sprawling, non-calcified distortion the dashed arrows are pointing to. That subtle architectural distortion, that is the truly fatal component that the lab tests completely missed.
That distortion is the real threat here. It's a diffuse malignancy, meaning it doesn't behave like your typical cancer. It totally fails to produce a dense central tumor mass. It doesn't have those easily visible calcifications that radiologists are usually hunting for. Instead, it creates this excess amount of newly formed fiber strands. On a mammogram, it literally looks like a complex spider's web. And because of that, it's incredibly difficult to detect early on, often just hiding out until it becomes physically palpable.
Section 3, diffuse versus solid forms. Let's zoom into the microscopic level and see how this builds a picture of two completely different diseases operating at the exact same time.
These tissue samples brilliantly show the duality of what this patient was facing. Under the microscope, we're actually looking at a combination of two contrasting forms of cancer. On one side, we see the solid invasive lobular carcinoma. Those are the large, contiguous clusters of dark purple cells packed tightly together. But on the other side, you see the highly dangerous diffuse form spreading silently, with huge amounts of connective tissue between the malignant cells.
Let's break these two down. The solid form is what creates those visible, circular masses we just saw on the mammogram. Because it starts in the cells lining the breast lobules, it packs tightly together. It's dominated by contiguous cells with very minimal connective tissue getting in the way. It basically behaves just like a traditional tumor mass.
The diffuse form, conversely, is incredibly stealthy. Instead of clumping into a neat little ball, it sends single file lines of cancer cells creeping out through the breast tissue. And these tiny, single files are separated by vast amounts of intervening connective tissue. This specific growth pattern explains perfectly why it doesn't form an easily detectable lump, but rather that deadly spiderweb distortion on the imaging.
Section 4, the origin of the cancer. To really understand why this diffuse web is so deadly and why our standard treatments fail against it, we have to look at its biological origins. The authors of this case study argue that this diffuse cancer is fundamentally misunderstood because of where it comes from. It undergoes a process called mesenchymal epithelial transition, or MET for short. Basically, this means the cancer doesn't originate in the expected epithelial cells of the breast. Instead, it starts in the hybrid stem cells of the structural connective tissue outside the lobules. It is a cancer born directly from stem cells, which completely changes the rules of engagement.
Because it comes from these unique stem cells, this diffuse form is an absolute nightmare to treat. It stubbornly resists standard chemotherapy. It shrugs off radiation therapy. And because of that resistance, this specific diffuse form maintains the highest fatality rate of all breast cancer subtypes. And sadly, that's a bleak statistic that hasn't budged an inch in 50 years, despite all our modern medical advancements.
Tragically, those grim statistics became the reality for our 90-year-old patient. Despite treatments based on her favorable lab tests, the cancer spread. What we're looking at here is the histopathology of skin metastases that developed on her back over 5 years later. She ultimately passed away from the disseminated disease 7 years after her diagnosis. It proved definitively that the imaging, that spider web on the scans, was the true predictor of her fate, not the optimistic lab results.
Section 5. A call for precision. This heartbreaking case brings us to the author's urgent plea to the medical community about how we classify these diseases.
Look, words absolutely matter in medicine. The researchers argue we have to stop grouping vastly different clinical diseases under the single, outdated umbrella term of invasive lobular carcinoma. When a solid tumor and a diffuse stem cell tumor share the exact same name, treatment protocols get confused. They propose renaming the deadly diffuse form to breast cancer of mesenchymal origin, or BCMO, to accurately reflect its true biological roots.
And that's exactly where the hope lies. By accurately defining this enemy based on its stem cell origin, rather than just how it happens to look under a basic microscope, researchers could finally develop targeted therapies. Acknowledging this could unlock brand new regimens that bypass its resistance to traditional chemo and radiation, which could absolutely save future patients. So this leaves us with a pretty profound thought. If an entire subtype of deadly breast cancer has been hiding in plain sight behind an inaccurate name and misleading lab results for half a century, what other misunderstood diseases are hiding behind outdated terminology? How many other lives could be saved if we simply learned to read the full story told by the visual evidence and biological origins? Thank you so much for joining me for this explainer, and remember, keep questioning what you see.